So we begin this afternoon with our afternoon keynote speaker, Kevin Oeffinger, known to many of you, who is speaking on reflections of 30 years of providing care for Hodgkin survivors. He is a family physician, the founding director of the Duke Cancer Institute Centre for Onco-Primary Care, the director of the Duke Cancer Supportive Care and Survivorship Centre, and professor of medicine with tenure in the Division of Medical Oncology in the Department of Medicine. The Centre for Onco-Primary Care has a fourfold mission. Firstly, to deliver evidence-based, patient-centred healthcare across the cancer continuum, enhancing the interface between cancer specialists and primary care clinicians. Secondly, to conduct innovative research with cutting-edge technology that can be translated to the community setting. Thirdly, to train and educate clinicians and researchers to extend this mission. And fourthly, to generate policy leading to practice redesign. Kevin has served as a clinician caring for Hodgkin lymphoma survivors for over 30 years and has had several studies supported by the National Cancer Institute aimed at improving the long-term health of Hodgkin lymphoma survivors. He has a wealth of experience, and I'm delighted to welcome Kevin Oeffinger to speak to us now.
Thank you very much. It's actually fun to be at a meeting and wear jeans. Aaron and Tess, super job on putting this together. And to our Leukemia and Lymphoma Society representatives, kudos for all that you do. Let me start with a few disclaimers. I gave a talk in Amsterdam in January when one of my very, very close dear friends is moving towards retirement, and we had a symposium for her. And I decided, rather than having our black and white data that we usually have for a symposium, I would tell the story through the patient's eyes. And that's what I'm going to do today. The faces behind our data. Who in here knows who Elton John is? Who knows who Bernie Taupin is? Oh, really good. Bernie Taupin is the lyricist for the majority of Elton John's songs, and he wrote a recent book called Scattershot. I absolutely love the book, but he said Scattershot because I'm not going to talk about things chronologically. I'm going to talk about them as they come to mind, and I'll do that. I'll do a little bit of chronology, but also just interposing things that I have learned along the way. We've already heard through this discussion, and Aaron, that was just a beautiful presentation earlier, is that we do face tragedy. I cannot tell you the number of very dear patients to me, to Emily, to Larissa that we have lost, that we became very close to. And so part of this is remembering our friends and our memorials to them and thinking through that. But I liked what Aaron said. We can either choose to sit on the couch and mourn, or we can put a foot forward. So there will be some positive notes here, but there's also some sad notes, some sad stories that I'll show you. And it's good because I've already seen crying here, so I don't have to remind you that it's always allowed. And my patients know that. And this is really the lessons that I think I have learned from my patients and my friends. Every one of you in this room has a story, and it's an important story, and it's a unique story. It's your story. I've chosen and selected a few stories that I think reflect some of the things that I have learned, but I could go on for hours and hours with the things that my patients have taught me. And a little bittersweet. I started taking care of pediatric cancer survivors back in November 1994, and I'll go over that in a moment. And December 13th of this past year, I stopped seeing patients. And so a little bittersweet as I've gone through this time period of reflection. And I say this to my patients all the time. I have received so much more than I have given. It'll be emotional, sorry. So my first brush with Hodgkin disease. Back when we called it Hodgkin's disease and not Hodgkin lymphoma, we tried to be careful of terms that we use for pediatric cancers. Wilms tumor, neuroblastoma, Hodgkin's disease. We didn't even use the C word. When I was a high school student in 1973, one of my friends, Doug, was diagnosed with Hodgkin's. And I can remember us going up to the hospital, a little small community hospital. I do remember Doug getting his lymphangiogram and the pain and discomfort and going through radiation. And at our 20-year high school reunion, my wife and I were attending and saw Doug. And by that time, I had been doing a lot of work in this area at UT Southwestern in Dallas. And I went up to Doug to the side and said, "Hey, Doug, you know, I know what you went through, and this is an area that I actually do a lot of research and do a lot of clinical care, and I'd love to be able to share any advice and input." And Doug's response was, "No, that was long ago. I don't want to go. I don't want to revisit that." And it simply reminds me that we each have coping mechanisms, and those coping mechanisms change over time, but we can't always help. As much as I wanted to, there was nothing that I could do at that time period, and he was not open to that. One of my early heroes here is in the left, that's May Wong, early in her career in Waco, Texas. I did my family medicine residency in Waco, Texas. As a quick side note, people always say, "Well, did you know the Branch Davidians?" I was through 2 emergency rooms, 2 hospitals in Waco. I was in the one where 2 of our officers were brought in when it actually occurred, and I was on pediatric county call when it all ended. The FBI, somewhat gopher, if you will, for Central Texas that the ATF had running errands, that went up to the door and picked up the cassette from David Koresh was one of my patients. So yes, I did live through that. Back to May. May is one of my all-time heroes and one of the most brilliant people I've ever worked with. She was trained at a hematologist when women were not supposed to be doctors and that sort of thing at Tufts, and then her husband was a physics professor, and they migrated down to Waco and to Baylor. And we always joked that there's the right way and the wrong way. And perhaps my most proudest moment is when my fellow residents awarded me the first annual May Wong Obsessive Compulsive Disorder. My second brush with Hodgkin's was when I was practicing as a standard family doc in Waco after my residency, and I saw Marcia. She was a young mother of 2, routine visit, taking a history. She had a history of Hodgkin lymphoma. She was treated with wide fields of radiation, nothing else that she remembered. And I spent a bit of time looking into the literature to see, is this going to cause a problem for her? She looked great. She was not having any health problems. She was in her early 30s. And at that point in time, in the late 1980s, there was no literature on late effects. The first 2 papers that came out looking at breast cancer following chest radiation for Hodgkin lymphoma actually came out in 1992, one from Sloan Kettering and one from Stanford. And I lost contact with Marcia over the years, and when I was preparing this talk, I reached out to one of my close friends to see if they could find out. And she ended up migrating to Houston, became a superintendent of her school district, having a very, very good, very productive life, and sadly passed away of lung cancer about 4 years ago. Another of my heroes is George Buchanan. Those in the hematology world all know him because of his major contributions to the change in care for sickle cell anemia. I moved from Waco up north to Dallas to UT Southwestern in 1993, and we were starting a new Department of Family Medicine. And George was extremely well known in the state of Texas and well liked. He was division chief of pediatric hematology oncology, and George came over with 2 of his pediatric oncologists, one of his nurse practitioners, and an administrator, and said, "Will you start a program for young adult survivors of pediatric cancer?" And I knew who George was. We, in fact, had taken care of some of his patients down in Waco with May Wong. And so I said, yeah, I'll give it a go at that. And importantly, George told me, he became a very close mentor to me over the years. He had knocked on many doors prior to that. And when I tell people that some of these things just take time, you just have to be persistent, have to be patient. I look back, I was trying to find some of the old pictures of George, and the picture that you see that's black and white is a very moving picture. The person in the middle, Bart Kamen, was also a very famous pediatric oncologist at that time at UT Southwestern, but later became the division head of Robert Wood Johnson, and a very good friend that sadly died of a very aggressive sarcoma during my years up in New York. So I did once have hair. We started our program that we called After the Cancer Experience ACE Young Adult Program in 1994. Deborah Eshelman is the second author of the paper. She's a nurse practitioner that I'll show in a moment on that. And this is just one of our pictures from our UT Southwestern. And as looking back, we were not great picture takers years ago. Of course, we didn't have iPhones on that. So this is a more current picture of Deb. But Deb, you know, I'm a family doc, and I understood how to work up chest pain, shortness of breath, et cetera. But she taught me about doxorubicin and what it was like for the kids going through therapy and all of the different things. And Deb and I worked together for 12 years and remain very close friends, and I'm very indebted to her. We've also mentioned Linda's name, Linda Gotina Zame. Linda reached out to Deb and I in our first year. She said, hey, I've got this listserv. Will you join it and answer some of the questions? And we got on the listserv, and there were about 1,000 emails in 24 hours. And I reached out to Linda and I said, listen, I am always available for you. You can call me any time of the day. I will do whatever you need, but I'm getting off of the listserv because I don't have time. And over the years, Linda and her husband, Bill, became very close friends. She was a confidant and a muse. Many of you probably don't know, but she was a Berkeley-trained psychoanalyst. And Linda and I used to talk about the timing of a cancer diagnosis with some of the ideas that we have of why did I develop this cancer and internalizing it to something that I might have done. And she's a brilliant woman. Another one of my heroes is Emily's predecessor, the very first director of the Office of Cancer Survivorship and an incredibly famous pediatric oncologist, Anna Meadows. Anna, when I was early on as a family doc, I reached out to her, and here is this incredibly famous person, and I'm just this little peon from Central Texas, and she took me under her wings and just taught me, again, speak your mind. She, in fact, once called me retarded because I had not yet been to the Louvre. And those that know Anna know how she didn't have a real good filter. But she was incredibly passionate about her patients and survivors. And she coined the term that has been used since then, maximizing cure, minimizing cost. And you see that coffee cup there. Anna gave that to me as a token of appreciation that came to her from Joe Framini. Joe Framini is of the Lee Framini, P53, a famous cancer mutation that Fred Lee and Joe Framini first described. And so that coffee cup still sits in my office, and it has great meaning to me. So let's get to some patient stories. This is Lisa, and Lisa taught me that one of the things that Larissa, Emily, Michael, and I, all of us should be committed to, and that's educating our community. I recognize why primary care providers, oncologists, cardiologists are not familiar, because let's face it, Hodgkin lymphoma survivors, or indeed many of our cancer survivors, are unique to their practices. Lisa was diagnosed with her Hodgkin's when she was 17 in 1982, went through fairly standard therapy at that time, including radiation to the mantle field, her chest area, and she had the red medication, adriamycin, doxorubicin. And prior to starting follow-up with us, she had breast cancer diagnosed at a very early stage, 4.5 millimeters, so teeny tiny. Nowadays, we would not even treat this with chemotherapy, but she was treated by a community oncologist in Texas, and in addition to her surgery, she had backbone of therapy that we use for many breast cancer patients, more adriamycin, which we think of as a contraindication now. And predictably, she developed very overt heart failure within 6 months. And her ejection fraction, which is normally around 55, 60, 65%, dropped down to 20 to 25%. And sadly passed away from heart failure at the age of 46. And I always think of Lisa, again, of educating, and don't assume that our community providers, even in an academic setting, are familiar with the problems that we see in this population. I was recruited from UT Southwestern up to Sloan Kettering in 2005. Emily, I pulled this picture out. This is our team. You see Emily right behind, on my right, your left, and 3 of our nurse practitioners, Roseanne Tucci, Joanne Candela, Beth Whittam, Amelia, who did our abstraction. The other gentleman in the blue shirt, Steve Martin, is a general internist that worked with us part-time, and then Jennifer Ford, our psychologist. And I always told Jennifer, if I had my way, I'd have 100% of my patients see her, because all of us carry a certain weight, a certain fear, a certain uncertainty going through the cancer journey. And Jennifer was amazing helping. And at this point, it's a real shout out to who I think is the heartbeat of our programs, and that's our nurse practitioners. I already introduced you to Deb. I worked with Deb for 12 years. Roseanne and I worked together for 12 years. Joanne Candela worked with Emily for many years. And then Kim Slauson is my lead nurse practitioner at Duke. And these are the people that prepare the notes. We were talking earlier, I think, about trying to get patients into Sloan Kettering and new patients. My nurse practitioners would spend 10 hours on the average patient preparing for them, sorting through the records, going through all the treatment summaries, putting it together, and then hours afterwards in the communication. So they're the heartbeat. This is Frank. Frank was one of my first patients that we saw at Sloan Kettering. You can see the very obvious physiologic changes, and in fact, you can even see that we've inserted a tube for feeding for him. There's Frank from the sideway. Frank was diagnosed with Hodgkin's at age 13 with the good cancer. In Canada, they called it the golden cancer. Our Canadian colleagues were even more frustrated. He had radiation to the mantle filled, and when we saw him in 2005, the die had been cast. You don't need to know all the problems he had. You can just look at the picture and see he had severe disease. And Frank lived only about another 6 months prior to passing away. And there's very little that we did other than palliative care. Roseanne and I went to his wake prior to his funeral, and his wife Anne-Marie and all the family came out to us and said, "You were so important to Frank." And I'm thinking, we did nothing. 6 months, and we basically just put Band-Aids on. And she said, "No, you're able to tell him why things occurred and put it into perspective so that he could die peacefully." And remind me, little things count. Loris, I feel like you with the video. I have a hard time reading this, but I think it's important. This is an email that came from his wife about 2 or 3 months ago from Anne-Marie. And I'm going to let you read it because I just start crying. But these stories go on. These connections that even 6 months that we knew each other, she still takes time to let me know how she's doing and how the family's doing, and the connections that we make. Pardon me, I apologize. Emily and Lursa and Michael and I, we've spent a lot of our time doing research. And I do think that we're trying to answer the questions that you want to know. I always tell my patients, my research questions come from the things that you come and tell me that you want to understand. And an area that I've been quite interested in is understanding breast cancer. And more importantly, not just understanding, but increasing our screening rates. The patients that Emily and I see, our screening rates are 99%. Patients get screened. In the country, it's around 20 to 25%. And the difference is patients sought us out, tend to be educated, have insurance, and they're motivated by their health. And so a lot of my studies have been across the US and Canada trying to increase screening rates for breast cancer. This is Jean. Jean was diagnosed with Hodgkin's when she was 16. Standard mantle, you see a little bit lower dose, 2400 centigrade. And one of our early chemotherapeutic protocols, age 36, going through our screening, she was diagnosed with breast cancer. Again, a tiny 5.5 millimeter breast cancer, easily treated with surgery alone. And we always recommend a bilateral mastectomy because the radiation was occurring on both sides. She had it, and indeed we found a very early invasive cancer on the right side that still was not evident on the MRI. So she went through her treatment and then endocrine therapy, and Jean's doing great, and has 2 very active kids. Stacy is one of my patients from Sloan Kettering that followed me down to Duke, Hodgkin when she was 18, treated with higher doses of radiation. And at the age of 43, her risk for breast cancer was 22% for the next 10 years. So 2 in 10 chance in 10 years to be diagnosed with breast cancer. In the general population, that would be about 0.5%. And so she had an abnormal mammogram that showed some atypical ductal hyperplasia, but not cancer. And she finally said, aha, to her husband, who did not want her to have a mastectomy. She said, it's my right, and she had her mastectomy and did quite well, and basically takes that risk off the table. We mentioned earlier, Emily mentioned Flora van Leeuwen. Flora is a very close friend from the Netherlands who is a cancer epidemiologist. Prior to the pandemic, nobody knew what an epidemiologist did, and I think nowadays most people do. That's Flora, her husband Rob, and I in one of the islands on the north side of the Netherlands bike riding. When I went over in January for her retirement symposium, she actually got knighted by, this is not the Queen, that's the mayor of her hometown, but she also got knighted by the Queen of Netherlands. But much of her work has looked at late effects of Hodgkin lymphoma. She is probably as published in this area as anybody I know. And some of the work is looking at having polyps as a precursor to having colon cancer. And then looking at the cost effectiveness of screening, and not just from the radiation, but also from the procarbazine, the P of MOP or the P of COP, or some of our other regimens that were used in higher doses. Sophia. Sophia said, yes, you may show my polyps. Sophia was treated at Sloan Kettering for Hodgkin at 16, treated with the radiation, and there's that P of the MOP, and had her breast cancer, but diagnosed early and did quite well. Had her first colonoscopy at age 50 and had 15 serrated polyps, and these are like jagged edge polyps that have a high likelihood of being aggressive. And each annual colonoscopy since that time, she's had 13 to 15 polyps. And much of our work in informing our guidelines has come from Flora and the Dutch group in understanding this problem. And Jean, if we revisit Jean, same thing. I told you about her therapy. She has multiple 15 to 20, 25 polyps each time. She was getting colonoscopies every 6 months and decided to have a subtotal colectomy. And going through the surgery was rough. It took a bit of recovery, but she's doing great now and hopefully has taken that problem off the table. Now, I've talked about our research, and sometimes you see these graphs, et cetera. We work hard. These are people that put in 80, 100 hours trying to answer the questions that are important to those of us in this room. And these are some of my close friends, even statisticians, the one in the my left, your right that you see there, Haya Moskowitz, is a biostatistician that's worked with me now for 20 years. So when we do our studies, when we do our analyses, she's the one that's running the numbers, but incredibly passionate about making a difference in the lives. In our breast cancer calculator, we met for a year and a half every week, going through 1,200 sets of radiation portals from around the country to be able to quantify the dose of the radiation and the field of the radiation. Emily, I don't know if you helped a little bit with that, but Donna Barneo, one of our fellows at that time, who was a general internist in Tel Aviv, helped us with that. But these are the people behind the scenes. When you see the publications that come out or the newspaper articles, et cetera. This is Megan and her husband, Drew, and their little daughter, Avery. Megan was diagnosed in 1999, age 13. A more contemporary dose of radiation, but still to a little bit wider field to the mental with a boost, and then her chemotherapy, and has gone through the litany of cancers, thyroid cancer, breast cancer. And then when she was 35, when she delivered Avery in a community hospital in North Carolina, Avery was very healthy. She did fine, but Megan called me in tears and said, "They tell me I have cancer spread through my body." And I said, "Slow down, let's talk about this." And she had been short of breath, and they did a chest x-ray and did a CT. And the CT, they thought, showed cancer spread all through that. But in fact, it's just heart failure. They had overloaded her with IV fluids during her delivery, and she did have some pulmonary nodules. And everything was fine, and she's doing great. But it reminds us of the uncertainty that we've already heard several times today, and I know each of you in the audience experience on that of, what my patients always say is, "Kevin, when's the next shoe drop? What do I need to fear next? What do I need to do? And what can I do to prevent that?" And I think the key for us, for providers, is being available, listening. I'm a huge believer of our psychologists and our therapists working with patients and teaching cognitive behavioral therapy and meditation. Helps with insomnia, fatigue, and certainly fears and sense of uncertainty. A common thing that Emily and I heard at Sloan Kettering, that we actually set up a peer support program, was hearing our patients, especially our women, saying, "I look good on the outside, I feel totally broken on the inside." So we set up a peer support program. This is Tony, one of my patients at Duke, who told me, yes, that resonates, and that's her husband with her. So I look great on the outside, I feel broken on the inside. Tony had her Hodgkin's when she was 18, treated with radiation or chemotherapy, had breast cancer, which she said no big deal, sailed right through it. She had a left subclavian stent at the age 40. She said, again, no big deal. And then at the age 52, she went into complete heart block. And when her pacemaker was placed, it basically uncovered really severe autonomic dysfunction. And this is her blood pressures. You don't have to understand anything other than her blood pressure at 1 minute is super high, and she is experiencing excruciating headaches, thinking she's going to have a stroke, and the next moment she's fainting on the beach. Her husband is paralyzed with fear that she's going to be out on a walk and black out on there, and that's her 24-hour blood pressure. And so having gone through multiple things that she was kind of used to, this comes up to one that just totally breaks down again. Feel good on the outside. Everybody says, "Oh, you look so great, Tony," but feeling totally broken on the inside. Sarah, did Sarah make it? You made my day. This is Meg's. Now I'm going to really cry. I'm sorry. Meg was one of our big advocates at Sloan Kettering. Had Hodgkin's, radiation, When I first saw Meg in 2006, she had completed the race across America, and everybody's going, my gosh, you're an athlete. In fact, she was the captain of our soccer team at Harvard. And what Meg says is, they never ask me how fast I go. She said, I'm running 4 days a week, but it takes me 15 minutes to run a mile. You walk faster than that. I went and had lunch with Shira and Meg's mom yesterday on my drive up here. This is my shout out to moms. I love moms. Ivy, where's your mom? I love moms. I have moms coming to visits of patients that are in their 50s. And the moms went through it, and so did the dads, but the moms really went through step by step by step when the kids went through their cancer on there. And Meg, after every visit, would call Susan, her mom, and go over a 1-hour debriefing with that, and really kept the person engaged. Sadly, Meg passed away during the H1N1 epidemic, awaiting a lung transplant. But what Susan, her mom, and Paul, her dad, and Wes, her widowed husband, did is set up a research fund that really invested a lot of work that Emily and I and others at Sloan Kettering did. And so keeping that memory alive, and I think of Meg quite often. And Susan's 81 years old. Absolutely beautiful. I stopped and saw her. She's dealing with metastatic cancer. She helped set up the support services for her community hospital in Manchester, Connecticut, and now is making use of those support services. I told you I'm going to ask you to stand up. Jessica, there we go. Jessica, I guess everybody had Hodgkin's in this group, huh? Went through a radiation, 2 healthy children, went through the breast cancers. Jessica and I actually got to know each other in New York when she came to Sloan Kettering, but then she moved down to North Carolina prior to me, had her aortic valve replaced, and then in the fall of this past year had a massive heart attack. And it looked as grim could look. And the cardiothoracic surgeon said, only with a heart transplant are you going to live. And Jessica, and she said, I may share this story, and she's more than glad to talk with. She was at first thinking, nope, I've gone through enough. But then her youngest son convinced her to get a heart transplant. And she looks absolutely beautiful. I told her, it looks 20 years younger. I'm going to go sign up for a heart transplant. Amazing, Jessica. This picture is just 3 days after your surgery. You look so good after that. I've had now a number, probably 24 patients with an organ transplant, most of those being kidney transplants, but we've had liver transplants, lung transplants, heart transplants. And I realize the question comes up, can I get that? And I think you have to be at the right place at the right time, but the technology is certainly there. The other thing that Jessica's experience reminds me of is Hodgkin community really is strong. And this is Sophia. And Sophia, I don't remember who the other person is. Gail. In the hospital visiting with Jessica. But that's this community here. And that community is important. I've mentioned at the very start, we go through a lot of tragedy. We've seen lots of sad stories. But that sad story keeps that person's memory alive. But also that community is there for supporting, building up one another, strengthening us. Ivy, I saw you and your mom back there. I'll say this in a moment. This is Ivy at her gallery. Ivy was treated for Hodgkin's in 1974. She's here with her mother, radiation to the chest and the abdomen. I probably shouldn't say, Ivy, you can I say what you told the cardiothoracic surgeon? I love Ivy. Whenever I saw her on my list, I got a great big smile, and so did Roseanne with that. Ivy has a great sense of humor. She had an aortic valve replaced, and she calls her valve Porky. But her cardiothoracic surgeon is a relative of the Hemingways, of Ernest Hemingway. Very prim and proper Connecticut heart surgeon, handsome, and Ivy, when she met him and he was going over what he was going to do with this surgery, after she had her breast implants, she said, "Don't you effing," and she used the real word, "mess with my, I'm proud of these girls." As many of you have seen, the radiation, and Michael's going to talk about this, you really can cause some very profound musculoskeletal problems. I've seen everybody in here holding up their chin, and it's just a struggle. And I think of resilience, and what I was mentioning to Ivy when we were talking is sometimes we think of resilience and post-traumatic stress being two ends of one pole, but they're not. They're totally independent. And we discovered years ago that people can be feeling positive feelings of resilience at the same time of feeling fears from post-traumatic stress. And that gets confusing to a survivor. It can be confusing to a healthcare provider, but they're very different, independent, but parallel emotions. And as I said, I always get a huge smile on my face seeing, "And your mom." Paul. Everybody knows Paul from Paul, this is a long time ago. Yeah. That's with Roseanne. That's at Sloan Kettering. Paul, Hodgkin, his radiation. Paul had two-vessel coronary artery bypass when he was 43. He's got a great story about that, Paul's heart. And then had a stent placed and carotid and a valve replacement. But to me, the most important thing about Paul, to him it's his daughter's graduating, but the most important thing is when I first met Paul, he had a tremendous amount of anger. He was mad he was in a bad relationship. He was mad at his radiation causing his heart disease. He was mad at the world. And Paul has grown tremendously, and I'm so happy when I think of that. Jennifer Ford worked with Paul, but I think just that acceptance, and I think it goes back to what Aaron said earlier, is you have a choice in which direction you're going to go with your emotions. And Paul, kudos to you of taking that anger and channeling it into the compassion that you have and your efforts in helping the community, and certainly your two beautiful daughters. We've talked a lot about peer support. I got to learn about peer support from this young man, Andy. Andy had Hodgkin's when he was 17, a little bit lower dose radiation. I was always hoping that as we got these lower thresholds, we would do well, but he had a mesothelioma diagnosed about a year before I left Sloan Kettering, multiple relapses and progression. And I, Andy again was one of those patients that I bonded with day one and had followed him for a long time. When I moved to Duke, his wife, Kate, was diagnosed with a glioblastoma. Many of you know that my wife was diagnosed also with the glioblastoma at the same time. And Andy and I talked every 2 weeks for about an hour and shared stories. We shared notes. How are our respective wives doing with their glioblastomas? They both had inoperable tumors. There was no treatment that they could receive that would be curative, only palliative. And it really taught me about peer support. And I learned so much from Andy through that experience as much as I gave to him. A true firsthand. Sadly, Andy passed away of his mesothelioma shortly after Kate passing away of his glioblastoma. A wonderful guy. His brother is a cardiologist and had adopted their 3 children. But great person. We've shared a lot of sad stories, and I know for people that have been more recently treated or more contemporary protocols, sometimes they think, golly, is this what I face? And it's an area that we continue to do research. We published a paper a couple of years ago looking at 3,000 Hodgkin lymphoma survivors diagnosed 1970 to 1999. And we were able to predict late effects in patients treated with fairly contemporary therapies. And we really have seen an improvement. Our radiation oncologists have improved the technique and the dose that is delivered. We've improved our chemotherapy. While Hodgkin's has always had a very high survival rate, it's taken a lot of therapy to achieve that. I think Emily nailed it in saying that there's always a balance between how aggressive we have to be, because if we have a relapse or if we have progressive disease, the additional therapy really puts us in a more problematic area. So it's always a balance, and I have great respect for our pediatric oncologists, our medical oncologists, our radiation oncologists working in this area. But I do think that we've made a lot of advances in the last years. I'm going to stop with a short film. It's just 2 minutes. This was back in the days of camcorders. You're going to see Susie. Susie, where are you now? There you are. Yes, Susie. Susie Lay is in this film. We've mentioned Linda. Linda Zame is actually in this film. But it's when I was at UT Southwestern, I was giving a national presentation to a large primary care research group, and I wanted them to understand the population that I was talking about. Again, not black and white. So it's the old camcorders. My son was in college. He edited it for me. So we're going to show you this just to give a little flavor of that.
Hi, my name is Terry.
Hi, my name is Jason.
Connie.
Hi, my name is Jeff.
My name's Winnie. Brenda.
Blaine.
Julia.
Hi, I'm Lisa.
Susan.
My name is Linda.
I had Hodgkin's lymphoma my senior year of high school, like 3 weeks before graduation.
Leukemia. GI leiomyosarcoma.
I had medulloblastoma. My cancer was wrapped around my brainstem.
Osteosarcoma. It was in my upper left arm.
When I was 12, I was diagnosed with non-Hodgkin's lymphoma.
When I was 12, I was diagnosed with ALL leukemia.
I was diagnosed with Hodgkin's in 1984 and was diagnosed again with breast cancer in 2000.
I am an oncology nurse, but I'm also a 3-time cancer survivor, surviving for 32 years now after Hodgkin's disease and then breast cancer and more recently bladder cancer.
I had Wilms tumor when I was 2.5, and now I'm 32 years old and I am a teacher.
I work in the medical field now.
I'm majoring in psychology.
I'm not able to work anymore. Osteoarthritis plays into it. At 18, when I had chemo and radiation, I was told I probably wouldn't be able to have children, and hence that is true.
Why am I a survivor and someone I met while going through it died? Why couldn't they survive? Guilt.
I don't drive. I live at home still, and a lot of times I feel like a little kid because there are a lot of things I can't do.
My hair has never grown back from the cancer.
As I have kyphosis in my back because of the Wilms tumor, and I have to deal with the pain of my back every day and trying to manage it and find ways to relieve the pain.
And I have underlying restrictive cardiomyopathy and chronic neck, back, and shoulder pain.
I like to think that we're no more delicate than any other person.
And that's it. Thank you very much.